Thank you for the introduction. So without wasting time, because we have limits of time and we will try to finish it on time. So I will be talking on the management aspect in the first line, where no TKI have been the standard of care, and now there is a lot of movement is going on in the field of immuno-oncology. So this is the spectrum, as Doval sir was saying. They have seen an era where there was no drug, only the combination of chemotherapy, and survival of hepatocellular carcinoma unresectable in a palliative setting was very dismal. Even the median survival was less than 3 months or 3 months, hardly. And then in 2007, the first movement happened in the field of palliating these hepatocellular carcinoma patients, where the trials sorafenib came, and subsequently we know that lenvatinib, regorafenib in second line, and there are a couple of molecules including cabozantinib, ramucirumab have come up. And now you can see in the last 3-4 years, we have plenty of plethora of molecules in immuno-oncology drugs have been added to HCC. But it is very important to choose these drugs, because we have been experiencing sorafenib. It's a wonderful drug, and we'll review the literature. It is very important to go into the history of the disease and treatment while choosing an agent. That gives us no idea. So we know that pathogenesis of HCC is very complex. There are downstream signaling happening from the tyrosine kinases, and VEGF is one of the important pathways. So if you look at the targeted tyrosine kinase receptors, in the first line, the approved agents in the TKI, sorafenib, lenvatinib, and there are multiple receptor tyrosine kinases are involved here. And you can see in the slide, so these are multi-kinase inhibitors have been the backbone of the therapy for hepatocellular carcinoma. So I would like to review the published trial of the sorafenib, wherein based on the two phase 3 trials, SHARP and SF-ACIFIC. Both are phase 3 trials, and based on this, the molecule came into first-line usage with level 1 evidence. So if you look at the trial population, but the only difference in SHARP and SF-ACIFIC is that SF-ACIFIC involved more advanced disease. If you look at the HBV percentage also, it is different. In SHARP, it was around 20% versus it was nearly 80% in Asia Pacific. So if you look at the median overall survival with the sorafenib was 10.7 months, 11 months nearly, and it was around 6.5 months with the Asia Pacific. So that shows that the disease was very much advanced in the Asia Pacific. Based on this trials, this came into use as a first-line agent. And it has worked in across all subgroups. But if you specifically look in pooled analysis of both the trials, lack of extrahepatic spread, HCV positivity, and lower neutrophil lymphocyte ratio were predictive of a greater overall survival. So if you particularly look at these particular things, you will get a more advantage by using sorafenib. Why it is important, in spite of we are in the era of immunotherapy and combination of targeted agents, sorafenib remains our choice of agent, and we'll review that in some insights. So coming to the side effects, so everybody is aware about the sorafenib side effect. I need not go into detail. So stating the fact that it is associated with a lot of side effects, but it is very important to tune the dose of the drug and to maintain the drug so that the efficacy comes with the continuation of the drug without dropping the drug. And everybody knows that there are a lot of side effects with the sorafenib. So there was a try to use the local therapies, which we have been used as we have been using as a bridge to transplant or resection. So local regional therapy like embolization or intraarterial therapies, these have been used in localized diseases. And there have been trials by adding these drugs, sorafenib with these local therapies. But apart from only TACTIS, rest all trials failed. So for the listener, it is very important, especially for the students, in the palliative setting, while choosing these local therapies, you have to be very clear your aim is not to improve the survival, because none of the trial had showed by combination of these local therapies with sorafenib has improved the survival. Yes, for palliation and symptom relief, these trials have helped. So what apart from trial happened? So this is the real world data apart from the clinical trial, because if you look at the sorafenib trial, only the childhood age patients were included, and here in the real world data you can see this has been used in childhood A, B, C. You can see the childhood C, the fetal survival to 6 months, but in childhood B, if you carefully select the patient, you can get the survival advantage. But in childhood A, you can see the 13.6 months, childhood B, it was 5.2 months. And if you look at the NCCN guidelines, the only agent which is approved to certain extent in childhood B is sorafenib. So this is again no adverse effect profile. I will not go. So it is well tolerated in the real world scenario also. This is the optimist data where the patients were referred for the local regional therapies, and if the patient is not eligible for intra-arterial therapies, the patient was referred for starting the systemic therapy. Based on when the sorafenib started, early or late, you can see those patients who immediately started on sorafenib, again in the real world data out of the clinical scenario, the survival was better. It was 16.2 months against those patients who deferred starting the sorafenib. You can see 12.1 months is the median overall survival. So sorafenib we have been using more than a decade. We have experience how to handle the side effect. So still in today's date, in spite of that there are combination of therapies or immuno-oncology or targeted therapies, this is one of the preferred agent. And one more important thing is the cost. So another agent is lenvatinib. Again, one of the agent which is acting on the tyrosine kinase VEGF receptors. Apart from that, there are other receptors where it acts. I have enlisted the list. So this is the trial, Reflect. It was again a phase 3 trial. It was an open label trial, non-inferiority trial. Based on this, 1:1 randomization, this is the overall survival. So the endpoint was met and lenvatinib was non-inferior to sorafenib. Median overall survival of lenvatinib was 13.6 months versus 12.3 months for sorafenib. So problem is that we have so many agents tested after sorafenib, but none of the agents have been tested after progression of lenvatinib. So this is the second agent which is available in the first line. So again, the PFS looks numerically better. Both are, because it's a non-inferior trial. Looking at the side effect profile, this is the agent where the side effect profile is little bit different from the sorafenib. In sorafenib, we know that hand syndrome is a problem. You look at lenvatinib, hypertension and proteinuria was the problem. So monitoring these side effects is very important when you think of putting the patients on lenvatinib. So lenvatinib was non-inferior. Again, I mentioned it was an open label trial. Usually we prefer the double blind trial, which is standard. So carefully, if you look at the inclusion criteria, patients with more than 50% of liver occupation and bile duct and portal invasion were excluded. So here again, they have selected carefully, those patients would have good outcome. Unlike the sorafenib, regorafenib, as I mentioned, there is a sequencing. Most of the trials have been tested after sorafenib. Again, we don't have a real world data of what to use after lenvatinib. So again, these points needs to be, and if you look at the resource data where regorafenib is used after sorafenib, if you look at the overall survival is in the tune of 26 months. And if you look at the updated data of lenvatinib, it is around 21 months. So these are some points which I would like to highlight. And these are all the trials where sharp SAPC reflects. You can look at the median overall survival. So after this TKIs, a lot has been tried, but now in last 3-4 years, there are agents coming in the trial of immuno-oncology in the second line, and the VEGF monoclonal antibodies like ramucirumab. So nivolumab and pembrolizumab have respectively been tried in Checkmate 04, and pembrolizumab was tried in Keynote 240. And based on this, these agents are approved in second line. Then they tried to bring the immune checkpoint inhibitors in the first line. I will not go into details of the mechanism of action as everybody is aware about how the IO acts. So this is the first phase 3 study of a IO drug, Checkmate 459, where it has been directly compared with the TKI. So this is a randomization and the primary endpoint was the overall survival. There was a lot of hope from this trial, and you can look at 12 months. The percentage of survival is 55% in the TKI and 60% in the nivolumab. And at 2 years, almost 40% of the patients are alive as opposed to 30% in the TKI. Same thing, but the end point was not met. The statistical value which was designed was not met. But what was important in this, irrespective of the PDL1, if somebody wished to use nivolumab in the first line, there is no need to do PDL1. Irrespective of the PDL1, it has shown the survival. What is here? The quality of life, the side effect profile, if you look, it is very well tolerated drug. So if somebody wish to avoid, you definitely have an agent, but there is no level 1 evidence. Here again, you have fact sheets. The quality of life is much better in nivolumab as compared to sorafenib. This is first line trial. So based on this, obviously there is no level 1 evidence being a superiority trial. So this drug has been mentioned in NCCN as a category 2B. If somebody wish to avoid all those level 1 evidence drugs, you can use, but with the lower level of evidence. So after failing to show the superiority of immuno-oncology drugs as a monotherapy, a lot has been happened by using the IO drug. Second line, these combinations have been tried, and with the positive results, they are trying to bring this combination into upfront. IO plus targeted therapy is also trials are going on, and one trial is positive, and the drug has come already into the first line use. IO and other is use of radiation, like other diseases. Everybody knows that we are trying to combine the radiation or chemotherapy along with the IO drugs. So what is happening over here? So atezolizumab plus bevacizumab. So this is the Embryo 150. It is again the first phase 3 trial, successful trial of combining the IO drug with bevacizumab versus sorafenib in the first line. So the randomization was 2:1, carefully selected patients. You can see the inclusion criteria. Patients with bleeding or high risk of bleeding were excluded. Now in Hepato Cellular Carcinoma, everybody agree with me, to select a patient with no good health, it is a very difficult thing. Again, the selection criteria includes a new point where the patients who had bleeding within 6 months prior to the enrollment in the trial were excluded. You can see the combination bevacizumab used was 50 mg per kg every 3 weekly with atezolizumab 1200 mg versus sorafenib standard dose. The co-primary endpoints was OS and PFS. So what happened over here? So again, as I mentioned, selected inclusion. Patients with variceal bleeding, a prior variceal bleeding within 6 months prior to the study start, history of hypertensive crisis, inadequately controlled hypertension, any evidence of bleeding diastasis is excluded out of the trial. So again, this is I will not go into the details of the patient characteristics. So this study has met a survival endpoint wherein 6-month overall survival rate was 85% and as against to 72% with sorafenib. So definitely a good results. Look at the PFS, 6-month PFS rate, again superior to the sorafenib. So atezolizumab and bevacizumab improved PSF over sorafenib, PFS as well as OS, and this has been reported before also. Looking at the responses, now what is the difference between the IO drug and the TKIs? If you look at the TKIs results, the response rate never matched with the survival. But in IO, if the patient responds, you can predict that patient is going to live longer. In the second line, with the newer trials or combination of Limo-Ipilo, those patients who had CR and PR, they did much better as compared to the stable disease. And the CR patients are doing, in terms of the Kaplan-Meier, they are sitting on the top of the graph. So here also, you get good responses. So although this demonstrated a consistent overall survival benefit versus TKI, most of the group, the pattern was non-inclusive of those patients. They have, as I mentioned, they included only BCLC stage B, C, and there were less representation of normal etiology of HCG, which is again increasing incidence of this kind of those patients who are non-hepatitis B or C positive. They are also developing Hepato Cellular Carcinoma. This population was not represented in this particular trial. Now, looking at what happened with the adverse effect, as we know, the IO has a different set of problems as compared to the TKIs. So, as you can see, the hypertension, as bevacizumab was used over there, proteinuria was the problem, enzyme elevation was bit comparable, you can see. So the most common grade 3-4 adverse event with this combination were the hypertension, proteinuria, and transaminitis. And with the sorafenib, we all know hand-foot syndrome is a problem, and high bilirubin. So here, the concern is we have already excluded those patients with the bleeding problems. Bleeding events occurred more frequently in spite of carefully selecting. Here again, the bleeding events have happened more frequently with this experimental arm compared to sorafenib, including fetal bleeding. Therefore, you have to be very careful while choosing your patients for this combination. So atezolizumab, bevacizumab definitely translated into survival advantage as compared to TKI. Serious adverse events and withdrawals were more common with the combination as compared to TKI. Higher proportion of patients of sorafenib went on to receive subsequent systemic therapy. So this is approved by FDA as first-line therapy. NCCN also mentions as a level 1 evidence in the first line. So looking at the quality of life, definitely the quality of life in terms of physical functioning, role functioning, and in terms of the symptom deterioration, time to symptom deterioration, the combination did better as compared to sorafenib. So this is what I summarized. Key inclusion, you have to be very careful selecting these patients. Bleeding was a problem. Quality-wise, this drug is better, and this is one of the latest option in the NCCN and other guidelines for using this combination in front as a palliative therapy for unresectable advanced disease. So now what is happening beyond this? So we have sorafenib, we have lenvatinib, and we have IO plus bevacizumab combination. Now this year, because this is the latest study 22, which was tried in a combination of patients, though mostly this drug used here in the second line setting, those patients who are sorafenib naive, or those refuse sorafenib, or those intolerant to sorafenib, or those who progressed on sorafenib, they tried to use the IO combination of tremelimumab with durvalumab, with durva monotherapy, tremelimumab monotherapy, and again the different dose combination of two IO drugs. Why it is important? As we know, the CTLA4 mechanism of action of the CTLA4 inhibitors, and that both have a synergistic effect in other diseases like melanoma as well as lung cancer, and after that they have tried here. So what is interesting in this, if you can see the first dose, tremelimumab 300 milligram and durvalumab. So they tried to give a single dose. This is a phase 1 and 2 trial in the second line setting, and few patients were in the first line. They give only one dose of tremelimumab as a priming, because there is a they tried to prime this by inhibiting the CTLA4, and then they continued only durvalumab. And this hypothesis proved, and you can see the median overall survival was 18.73 months. Excellent. But this is again a phase 2 trial, and they are trying to bring this into a first line now in the form of Himalaya trial. So this looks promising as a combination of IO. Even with the single agent tremelimumab, the numbers looks very good, 15.1 month. So again, I will not go into this thing because this is again a hypothesis, and this combination, as I mentioned, is coming into the form of a phase 3 trial, Himalaya trial. So what are the ongoing trials going on? So you can see the Himalaya trial, as I mentioned, which will get finished this year. So maybe ESMO or next year's ASCO will get the results. This is a first line. So we have a promising combination coming up next year, form of IO. There are other combinations like TKI, like cabozantinib and atezolizumab in the first line again. Most of these drugs are compared to sorafenib. As I mentioned, there is no positive trial post lenvatinib. So coming to those patients who are going to progress, you can see the combination of lenvatinib and pembrolizumab. So we will have a trial where they are comparing with the lenvatinib again in the first line. This may take around 2-3 years, and there are combination of nivolumab, ipilimumab based on the phase 2 data coming from the Keynote 040, Checkmate 040. It is difficult to remember all this stuff. Checkmate 040 has one of the nivolumab, ipilimumab, and it was again a promising in second line. So they are bringing this agent into first line, and here they are comparing it to TKI, sorafenib, or lenvatinib. Again, it will take 3-4 years. So what is now in the present time we have? So I'm not going into details of the intermediate stage disease. So we are focusing here for advanced stage palliative setting. We have sorafenib since last more than a decade. Everybody uses it. Everybody knows it. It's a toxic to use it. But what is important for sorafenib, you have to titrate the dose and make sure that the patient remains on sorafenib. I have personal experience of toxicity with sorafenib. It takes your head. It is problematic for the physician also. But if you can carefully maintain the dose or reduce dose, in the real world data also, those patients who maintain the lower dose also, it has translated into better survival. As I mentioned, the response rate here in TKI doesn't correlate with the survival. So make sure that you maintain. You see excellent results with sorafenib sometime. Most of the time you deal with the toxicity only, but it's a good drug. It is going to remain there because we can see the combinations are being compared with sorafenib as standard of care. The next drug is lenvatinib. You can select, but as in the trial inclusion also, you can see that population was carefully selected, that more advanced disease they have excluded from the trial. And the third combination is atezolizumab, bevacizumab. But again, we see if patients in the trial are carefully selected, in spite of that, they faced with the problem of bleeding. So when you put patients on combination, you have to be very careful. And as we know, Hepato Cellular Carcinoma affects the liver, where the bleeding things are controlled in the liver only. So you have to be very careful while monitoring the toxicity in terms of bleeding and hypertension, because you have obviously added the bevacizumab over there. We'll not go into the second lines, but most of the second line trials have been tried after sorafenib. And if you so this is just to show the survival, how the survival has improved. If you can see the sharp on one end, and I am Brave 150 on the other end. Even in the comparator arm, the median overall survival with the sorafenib was 10.7 in 2007, and now we are in 2020. You can see this checkmate 459 and I am Brave 150 has improved the survival up to the tune of 15 months with the sorafenib only in the comparator arm. So sorafenib is a time-tested drug. It is going to be there. We are comfortable with using oral drugs. Patients are also comfortable using the oral drug. The problem is the toxicity, but yes, titrating the dose is important. Most of the second-line trials are post-sorafenib. Lenvatinib is an alternative, but we have to be careful while selecting the advanced stage disease. IO monotherapy has failed in the first line. That incited combination of IO and IO targeted therapies. One of the combination has already approved in the first line. The combination of tremelimumab and durvalumab is very promising. You can see the median survival in the stage phase 2 trial is almost 19 months. So this is what we have reviewed the data, and thank you, Sachin, for giving me opportunity to be a part of this important meeting. Yes, there is a lot much happening in the field of immunology, but still those old drugs are going to remain, and we have to use these drugs one after the other so that we can prolong the survival of the patient by judiciously using these drugs one after the other. And I conclude my talk. Thank you.